As everyone knows, we're all taking turns with grand rounds, and this is nursing's time to present. I just wanted to, first of all, introduce myself. So I'm Angela Leahy. I am the patient care manager for the T1 and M6 outpatient clinical areas, as well as nursing, chemotherapy, and the specimen collection areas. Today, the goal of our presentation is really to raise awareness and answer questions that people might have. I'm sure many of you, for many different reasons, have been curious about the activities of Clinic C and what's been going on there over the last couple of years. And certainly now there's a new area up front, which today the goal is really to answer some questions around that and raise awareness about the activities that are happening in that space. One of the things I'd like to do before we get started is just introduce the people that will be presenting today. There's a number of us, and we do that for a couple of reasons. One, I always feel it's best to have those that are responsible for both the practice and the operations of the area to speak to the area. We've divided this presentation into 3 areas with key speakers for each of the areas. It also keeps it interesting for you guys. So from the operations side of things, I certainly want to introduce Kirsty Wield, who is one of the supervisors, and she's primarily for the chemo suite and has just taken over the lab. Dawn Knight, who is one of the supervisors as well, that is responsible for a number of key areas as well as the T1 clinics. And Vahab Atefy, who is responsible for some key sites as well as the Inject clinic. On the practice side of things, we have Angela Boudreau and Chris Nitsopoulos joining us. They are both advanced practice nurses. Angela oversees a number of sites and primarily the chemotherapy area, and Chris as well, a number of sites. And he has really been leading a lot of the work as of late around the nursing assessment area, which you'll learn a little bit more about today. One person that is not present, I'm not sure if she's been able to join us, is Virginia Waring. She's our data analyst that we acquired several years ago within nursing, and she has certainly been instrumental in all of our work, but primarily also as of late the work of Clinic C. So whether Virginia's joined us or not, I just want to thank her for all that she's done to help support our work. So moving forward, I'm going to just kick off with a couple opening slides. I just want to review our objectives with everyone. So I mentioned that the goal was to provide an overview of the patient care activities that really are occurring in Clinic C, which is located on the first floor of the Odette Cancer Center. You're going to get, although Inject has been around for several years, we are going to give just a quick update on the Inject clinic, but we're also going to highlight the newly created Infusion clinic and the newly created nursing assessment area. And as we move through each of those areas, we'll be going over a little bit of background, what the main purpose and goals are, some of the activities that happen in that space. And what I can do is pause to ask if there are any questions. And if not, we'll continue on. Clinic C really has been an evolution over the last couple of years. Certainly in March of 2020, there were very few in-person clinics happening in the outpatient area because of the pandemic. And there was a need as of March 17th to start doing COVID testing and assessment in the Odette Cancer Center. It originally started in Clinic B. We have since moved it to Clinic C, but this is where nurses were primarily providing all of the assessment for anyone who had shown up at the door with symptoms, anyone who had had a known exposure or a known were very symptomatic and a suspected diagnosis. We bring them in and do all of the testing and assessment in this space. And that's really been at the forefront of what nursing has been doing in that area. We'll talk a little bit more about how later that year, because certainly COVID testing wasn't going anywhere, we decided to move the Inject clinic into that area. It had been down at the back of Clinic A. We brought it into the Clinic C space, and really the goal there was to streamline nursing resources. There was no reason why the nurses in the Inject clinic couldn't also help with the COVID testing, and the nurses who were doing COVID testing could also give injections. So that was a conscientious effort on my part to help streamline and share nursing resources. Then January of 2022, certainly there is still COVID assessment testing going on in Clinic C, not to the extent that it was. There's obviously still injections going on in Clinic C, but then became the opportunity to move some activity from the chemo unit into Clinic C. And I'm going to leave that for Kirsty and Ange to speak to. And then last but not least, just in May, weeks ago, we launched the opening of the nursing assessment area, and we're going to give a little background on how that came to be. That was well in the works for many, many years before I ended up in a patient care manager role here. So it just so happened that it was coming about just around this time. And although we would like to have a little bit more data in that on the nursing assessment area, we think it's important at this point to even just let you know what the plan is and what's going on in that space. So I'm just going to pause right now and ask if there are any questions at this stage. Feel free to type them in the chat. Otherwise, we will move on to talking about the Inject clinic.
Hi everyone, Vahab here, supervisor for a few sites, including the Inject clinic. I'm going to be going over just some information pertaining to background, purpose, and goals with you, and start off with the background and what led us to implementing the Inject clinic, which took place back in 2018. What led us to that was based on observation, discussion, and just taking a deeper dive. We noticed that there were many medications which were very specific to disease sites, and the expertise requiring to facilitate those injections, we were limited. And we wanted to have more resources that can facilitate the injections safely. And one other areas that challenge we noticed was some sites had a larger volume presenting, impeding on clinic flow, which meant if the patient only was there for an injection, it would mean that they would have to wait a little bit longer in order for them to get their injection. So there were a few very distinct challenges that we noticed, and this led us to implementing Inject clinic. The pilot was back in January 2018, and we had to do trial and error a couple of times and make it a more robust flow and process. And in May 2018, we launched, the official launch took place. So this has been just over 4 years of implementation of Inject clinic. And the key focus really was to develop a consistent approach for injections. And moving on to purpose and goals. The main focus purpose is was and still is to enhance the patient experience for those receiving injections and optimizing nursing workflow, and certainly collaborate with other key stakeholders, healthcare team members such as physicians and pharmacy, and be able to streamline the clinic process. And the goals that we wanted to obtain was create more clinic efficiency to enhance the experience, overall experience of patients where they're directed to inject. And in return, that actually has created more clinic space when patients are going directly to Inject clinic. As mentioned, collaboration with pharmacy and physicians is essential. And the nursing knowledge and expertise in medications more consistent across all disease sites was also a very important goal for us. And patients experiencing more or less wait time surrounding their injection.
So as both Angela and Vahab have mentioned, the Inject clinic has been the longest running area in the area of Clinic C at this point, and obviously has evolved over time with both the needs of the patient populations as well as trying to coordinate the staffing needs. So when we think about the roles and responsibilities within this clinic, we can divide these into these 4 major groups that you can see. So within the assessment area, obviously in the height of pandemic, we were staffing the COVID assessment, as Angela alluded to in the very first couple of slides. And we were doing the assessment and the testing separately, but then as time went on, and again, the needs of that particular population were decreasing, then that particular aspect of the role was added to the Inject nurse role as well. As well as the COVID assessment, we also had TB screening and reading. So the Inject nurses, along with specific clinic nurses, can do TB screening or assessment and the injection of the tuberculin, as well as the subsequent reading. So that's one area of the roles. Another one is the administration, and obviously the administration of subcutaneous or intramuscular medication, the injectable medications, is the main responsibility of the Inject nurses. And within those, hormones obviously are the largest group, as we can all allude to when we see our GU site groups coming along. But it also includes areas like clinical trials. It also includes things like colony stimulating factors. And those are just a few of the more than 25 medications that are listed in our data as possible injections as we go along now. And that list grows as the need expands. So we're continuously evaluating what that list is and moving it forward as we get new injections. I want to comment on a bit of a challenge that is to the Inject clinic, and that's around medication administration. And that is the multiple sources of an order. So when a patient is a walk-in to the Inject clinic with a medication in a box, the nurse is going to look for the source order or the order source. They'll end up checking OPUS, Sovera for a written script, prescription writer, and have also checked verbally with our own pharmacy as well as outside pharmacies looking for the source of the order when they cannot find it. And this can be very challenging to people because, as you can imagine, some of these orders, for example, for the hormones might be every 6 months, and they may date back a couple of years because there's a prescription, but there's also a refill on that prescription for a few years. So this just is one of the challenges that we face with the medication administration. Along with the administration, obviously, is testing as the same kind of category. And this is where the COVID testing has continued within this area, along with the assessment. When we move to the patient teaching and education, from the patient teaching area, patients are receiving meds for the first time. So patients that are receiving those medications for the first time are provided with the education on the medication and around their side effects. And then as medications are given, during the course of the discussion with the patients, there are also possible teaching moments because that's going to depend on what the interaction is with the nurse. The nurse will check in and see what's going on with the patient and may reinforce information that had been given previously. A portion of the work also, as far as patient education is concerned, includes teaching patients how to self-administer injections. Now, this resides predominantly around filgrastim and pegfilgrastim, but it also requires, as a result of that, I should say, it requires ongoing communication and collaboration with pharmacy, as the Inject nurse most of the time will know about the teaching through that communication with pharmacy. In other words, they may get a call or an email that will identify the patient needs teaching either that day or the next day for a self-injection. As you can imagine, this would be vital communication, especially on a Friday when the patient will have to self-inject on the weekend. Additionally, Inject includes clinical trials, and the most recent clinical trial in Inject, the Sorrento trial, involved an arm that actually has the patient being taught, as well as self-injecting for 3 visits prior to continuing self-injection at home. So it's just more about the patient education and teaching. The final category is about patient monitoring. And the Inject nurses will monitor patients who are receiving a medication for the first time. They usually monitor them for about 15 minutes to ensure that there are no further issues. Some clinical trials require monitoring. And so again, this will be completed with the Inject nurse. And then finally, as new medications come out, such as the Evusheld, there may be some monitoring involved. So the recent Evusheld is currently for subgroups within the hematology population to subsidize or offer more protection against COVID for the immunocompromised population.
Oh, no, it's freezing. Oh, what?
So this was started in the Inject clinic with our first patient on May 16th. Next slide, please, Ange. So just to give you a little bit of information around our data that we have collected regarding the Inject clinic. To start off, I want to say that medications still occur in clinic areas of T-Wing, as well as M6, as well as in chemo, as well as in the nursing assessment office, formerly known as the pager office for radiation. But the majority of the medications are injected in the Inject clinic. So the data that I'm sharing with you on this particular slide excludes M6, and it excludes any injection activities that have occurred outside of the Inject clinic. When you're looking at the slide, on the left, you can see the activity over the past year, and this has been taken from the electronic documentation in Mosaic. So we've seen just under 3,000 patients and given more than 25 medications. And that's more than 25 because our clinical trial category is a category, but we haven't included the specific trials, but we've been involved in 3 clinical trials. We've given over 3,100 injections, excluding TBs and vaccinations because they have their own sections. We have given vaccines and we have given TB. And we've had some patients receiving more than 1 injection. We've completed 50 tubercular or TB injections and readings. We've given 124 vaccinations. We've completed over 400 teachings or educations, and we've completed over 400 COVID assessments and COVID testing. And this is over the past year, from May of last year to the May of this year. On the right side of your screen, you're actually seeing what the top 10 of the total of 25 possible medications. So we've just listed the top 10. We've collected this data from when we first started in the Inject. And so when we look at the medications, these are not surprising medications, nor have they actually changed over time. I want to note that the Evusheld, which I just alluded to, started in the Inject clinic basically to get it moving. But as the subgroups expand, the Evusheld assessment and injection will be moving as the needs are increased, and the needs of the population will need an increased capacity. But I will say this, if the Evusheld had continued in the Inject clinic or will continue, it would certainly make the top 10 list because in the last 2 weeks, we've given more than 12 doses. So I know that would come up there somewhere. While these are 2 areas for the data to be pulled and shared, there are other data that we are also able to pull, such as the days of the week, the busiest days of the week, what's been going on each of the days of the week, the busiest time of the day. But a current limitation to our data pull from a clinical documentation relates to the patients that are added into the clinic or just coming into Inject from clinic. And that is something Vahab and I have manually pulled that data previously this year. And that pull enabled us to make some staffing adjustments. But there is a way that we can have this on an electronic pull in the future, which will help us reflect what is booked and what is not booked into the Inject clinic electronically. Next slide, please.
Thanks, Angela. So this is the process for booking patients into Inject clinic, and two different processes attached to that. So one is same day appointment, and the other one is future appointments. I'll just go with same day appointments first. That is, patient was not booked in advance. Patient is in clinic seeing a physician to do for an injection. Patient the order is put in the system. Patient sent to pharmacy to pick up the medication from pharmacy. A call needs to be made to Inject clinic, and the extension is there, 683652, to notify the nurse that the patient is going to pharmacy to pick up their med, and they should anticipate to see the patient there shortly. And the patient needs to be instructed to wait outside clinic C area, where the nurse then will come out and call the patient and provide the injection. One thing I'm going to stress on is the staff, and in particular GU clinic, have been notified that If the Inject nurse happens to be busy, then the injection could be facilitated through clinic by the nurse there, provided the nurse has the knowledge and expertise to provide that particular injection to the patient, just to make things a little bit more efficient and less wait time for the patient. And the other process is for future appointments. That is, as we all know, we sheets out and with CPOE being rolled in. The order needs to be entered where it's for injection, depending on which site is specified there. And it's for nurse to see, and the date needs to be indicated there. And the note to UC needs to be mentioned, book this to inject. And the UC will pick up that order and look at the system for Inject clinic. And then we can capture that in the system in advance. And it's a better way to organize ourselves. We know exactly the number of patients that are coming in ahead of time, and we can organize ourselves a lot more, much more better.
Okay, thank you so much. Just before we move on, okay, great, Ange. I see you saw Dr. Gandhi's question in the chat. Thank you for responding. In the interest of time, again, if anyone has any questions, please type them in the chat. And if we don't get to them throughout the, I was gonna say podcast, if we don't get to them throughout the presentation, we'll make sure we address them at the end. So moving right along, thanks again to Angela and Vahab. I'm gonna continue with Angela and add in Kirsty to talk about Infusion Clinic.
Thanks, Ange. So I'm Kirsty. I am the supervisor of the chemotherapy unit, the specimen collection unit, and recently the infusion clinic. So the infusion clinic was created as of January of this year, and it was developed and integrated into an existing nurse-led area in Clinic C. So it was created to move some non-hazardous, non-chemo infusions out of the chemotherapy unit. And I'm sure all of you, or most of you, can recall messages being circulated, especially late last year, that chemo was in gridlock. Seemed like we were getting them day after day, week after week. So, you know, that really kind of, it was a place to stressor on everybody, the staff in the unit, everybody, stakeholders. So a working group came together to explore an array of strategies, saying, what can we do? What can we do to get rid of this gridlock? What can we do to get, you know, rid of patients waiting to come in for their chemo appointments? So through many collaborative conversations, the conversation and the concept of an infusion clinic was brought to light. So what would that look like? We considered the best possible types of infusions that could be relocated out of the chemo clinic into another area, but keeping in mind that we wanted to relocate treatments that were non-hazardous, non-chemo, low risk, and had a high patient volume that we were currently doing in the unit. So what did we come up with? We came up with zoledronic acid appointments. So what is zoledronic acid? This is what classified as a biphosphonate. It's not a chemotherapy. And what it does is it lowers the high blood calcium levels by decreasing the amount of calcium released from the bones in the blood. So we pulled data from CHARM because we wanted to make sure that this was going to be worthwhile in terms of choosing this patient demographic that would be moved out of the chemo suite into the infusion clinic. So like I said, we pulled data from CHARM from February of 2021 to October of 2021. And what this did was it gave us the patient numbers for each month. On average, we were seeing 163 patients per month. And we could also indicate what were our high peak days throughout the week. And as you can see, Tuesdays and Thursdays, we were seeing most patients with this treatment. So Meta infusions, they're booked for a 45-minute chair time. It's an actual 15-minute infusion. And setup time and takedown time is included in that 45 minutes. So if on average there's 163 patients a month and we're timesing it by 45 minutes, on average, 122 hours of chair time would become vacant if these patients were moved out of the chemo clinic into the infusion clinic, which is a surmountable amount of chair time. So those patients on a wait list, new patients waiting to get in, clinical trial patients, that freed up chair time would allow these patients to move into that time. So although the infusion clinic is located in Clinic C, it's part of the chemo suite within our CHARM booking system. And what it does is we had to create a new zone in the system to have these patients assigned to a specific chairs within the infusion clinic. So our workflow is the same in terms of approving patients, pharmacy mixing, and delivering meds that we follow in the chemo suite. And this is all done through CHARM. So currently our focus is on zoledronic acids, but it also focuses on supplemental infusions such as magnesium infusions, calcium infusions, phosphate infusions, potassium infusions, and hydrations as well. Another reason why we chose non-chemo, non-hazardous drugs is that we don't have to have certified chemo nurses to work in this area to be able to infuse these types of medications. And this was really important for us because we knew offhand that we couldn't offload any of the chemo nurses to work in the infusion clinic because, you know, to be honest, we were having our, you know, it was the peak of COVID. We were having issues with resources and staffing. So like I said, we didn't want to offload any of our current staff into infusion clinic. So I collaborated with the supervisors from the infusion clinic and pulled nurses from the clinic area in to work in the infusion clinic. And we're still in the midst of cross-training some staff. So what was the purpose of the creation of the infusion clinic? Really, it's to enhance the patient experience for those receiving non-hazardous medications via infusion while maximizing the capacity in the chemo suite that were, you know, for patients requiring hazardous chemo drugs. To note, even though we're doing zoledronic acids, we're doing single agent zoledronic acids in the infusion clinic, meaning there are some patients who come in currently that receive zoledronic acid in conjunction with another chemotherapy drug. Those patients will remain to get those Zometa in the chemo clinic just because they are receiving another chemotherapy drug. So instead, it just makes sense to keep them all in one area versus, you know, transferring them to the infusion clinic for one of their two infusions. So the goals of the clinic, obviously, to free up capacity in the chemo suite for chemo infusions, manage our gridlock issues, optimize the workflow for staff and for patients, and most importantly, enhance the patient experience. So the nursing roles and responsibilities for the infusion clinic nurse, we wanted to create almost a one-stop shop for these patients. Because previously when they were booked in the chemo unit, they would, you know, visit the assessment nurse, then come in for their treatment, etc. Through discussion with, you know, our working group, we deemed that it was most important to, you know, kind of train these nurses to do every aspect that was required during the patient's appointment. So beginning with prep or chart prep. So looking at the next day's patients, seeing what they were booked for, if there was blood work resulted, if there was blood work entered, if there was orders present. And we do have pre-approval criteria in which patients can be deemed to be pre-approved if there's orders in the system, if it's non-same day blood work, and a telephone assessment is done and that it comes out satisfactory. What that does is it helps expedite and also helps decrease their wait time while they're here, because their drug should be ready by the time that they arrive for their infusion clinic appointment. And it skips a step in the process in terms of patient assessment, because the telephone assessment can be done the day before. So again, decreasing the time that they're here for their appointment. So we had to get these nurses also in terms of documentation. They were documenting still within the same system, but in a different area. So it was getting them familiar with what needed to be documented and where it needed to be documented in the nursing documentation system. The nurses had to get kind of refreshed with or even trained on IV starts, CVAD access. A lot of our patients, because they've received prior chemotherapy, still have central lines, so PICS ports. So getting familiar with that and comfortable with that nursing role. Patient education is a large component of this role as well, especially for patients starting zoledronic acids. So new patients, number one treatments are done in this area as well. So just going over with the patient potential side effects, et cetera, and contact numbers and who to contact if there is an issue. What coincides with patient education for the first visit is a vein assessment. If patients are arriving and they don't have a central line in, we always do a vein assessment to look at the acuity of the veins based on, how long they're getting the treatment, and doing education with the patient on that. Obviously, the administration of the zoledronic acid is a huge component of this role, but also the nurses in this area do manage add-on requests, whether that's coming from the clinic side, whether that's coming from, chemotherapy. For instance, if a patient's chemo is canceled, but the physician wants to proceed with magnesium, we would then move the patient over to the infusion clinic for that infusion, again, to free up chair time in the chemo suite. And also, patients in clinic, if, they're seen by the physician, need hydration, possibly waiting for an admission, they would all be, it would be done in this area also. The nurses also support other clinic activity within Clinic C. They've helped out with the COVID swabs, et cetera. So as you can see, it's a lot of, duties that they're responsible for, that they've had to be educated on. And this is an ongoing, thing, in that we are continuing to cross-train nurses into this area so that we can create, a pool large enough that will assist. We're looking to evolve this clinic over time. There have been a nurse who has gotten chemo certified. So we're looking to further certify more nurses. And like I said, looking to evolve this area in terms of looking at other non-hazardous drugs that we can then integrate into this area. And again, it's to free up the chair time in the chemo suite to decrease the wait times and also allow us, to get more patients in. So what does the data look like from when we went live with this area until present? So we pulled data from Charm indicating what the infusion volumes by month look like. I would say January and May are outliers just because the data kind of starts and stops, in the middle of the month. So if we look at February, March, April, we're seeing about 132 to 164 patients a month. If you average that out, we're looking between 100 to 125 hours of time occupied in the infusion clinic. And again, that is time that has freed up space in the chemo unit because these patients have been moved over to this area. If you look at the percentage of infusion volumes by regimen, you can clearly see that, over 90% of the infusions we're doing right now are zoledronic acids or zometas. Pimidronate is a very, very small percentage. Again, that's a biphosphonate with the same intent as zometa. And we are doing supplemental hydrations, magnesiums, sodium phosphates. So again, I think 123 hours of chair time per month is very significant. This data is showing that we really did choose, a great treatment or regimen right off the bat that would have significant positive impact on freeing up chair space in the chemo clinic. And again, most importantly, feedback from patients overall has been positive. And just in this bubble on the top right hand corner, it was a testament from a patient stating, last week was my first Zometa infusion in the infusion clinic, and it was 100% better experience for me. I was able to let go of feelings of guilt for having my hair and doing well compared to others. I had no feelings of anticipation or anxiety facing the chemo suite after months of chemo treatments. So, I think this really is a, tell-all to the impact it's having on patients. It's not to say that we don't, get the negative, the negative comments and that there's no windows, because if you've been through the chemo suite, it's very open, it's very bright. But you know what, this type of treatment, it's a quick infusion, it gets the patients in and out, it is decreasing their wait times. So I think it's been, a win-win. And as I mentioned before, we're looking to evolve the clinic over time. We have some preliminary ideas, and we'll see where it goes from here.
Great. Thank you very much, Kirsty and Angela. Again, if anyone has any questions specific to the infusion clinic, feel free to type them in, and Kirsty and or Ange will respond to that. In the interest of time, I'm going to move us on to the next and final segment of Clinic C, is the nursing assessment area.
Good afternoon, everybody. So I'm Dawn Knight of the Nitsopoulos Dawn Knight, part of the presentation. So we're going to share the work that we've been doing around the nursing assessment area. So as Angela had explained at the beginning of the presentation, this has been in the works for quite a few years. However, we were informed about a year ago around this time that we would be getting 4 new desks and that they would be provided to nursing. And of course, everyone has noticed now that the hoarding has come down, and that was around the end of April. And we've got these, as the picture indicates here, 4 beautiful desks, a lot of compliments on this space that has now become present for everybody. So this is located just outside of Clinic C. It is at the main part of around the T1 reception area, so just adjacent to where patients would complete their registration and their ESAS, the symptom screening with our screeners. And the 4 new desks have given nursing the opportunity to be situated more front and center, very much like a nursing station that you would see on the inpatient units. This has been a year-long process in planning. A working group was brought together and began to explore options of how we could best meet the needs of our patient care needs, and of course the current state of the flow of patients through our clinics. The working group didn't include feedback from a number of our key stakeholders within the center itself, involving nursing, our physicians, our senior leadership. We all collaborated on the development of contributing to making this area a more efficient experience for the patients that were coming to the Odette Center. So I'm going to just explore a little bit with you, everybody, the purpose and the goals of this area. Again, we've only been in operations for about a month now. And the purpose of this space, we had envisioned it as a centralized nurse-led assessment area. We wanted to enhance and augment the patient experience. We want to streamline the patient care and create clinic capacity. It's a space for nursing to be readily available for anyone who walks through the Odette nursing doors that are unwell and they need immediate attention. We wanted to reduce the wait times for those patients needed to be seen in the clinic, in terms of communicating that need to our clinics and to our physicians within the clinics for those patients coming in, or those who either have or do not have an appointment specifically booked. The spaces for any clinician and a non-clinician, their patients, the families, to identify a patient in need of care and to bring it as efficiently as possible to the attention of a clinician for further assessment. Some of the goals that we've put in place at this time, based on the feedback of the work through the working group, is to the nursing assessment. We want to support all members of the clinic team. And this is across all disease sites. So it's irregardless of what site that patient is coming from. Those 4 nursing desks are to support any patient that's coming in at any time. We want to remove any activities from the patient care area that might interrupt clinic flow. And we want to give the patients an overall better experience. So looking at some of that work, it's some of the work that might take a nurse in the clinic a little longer to address with the patient within the clinic setting. And we can take that work and move it out to our nurses that are situated at the nursing desks. Another goal is to support the link between our phone nurses and our clinic nurses. We call that promoting a triad approach, and that triad approach is connecting our nurses that are on the phones that may receive a call from a patient saying, you know, I'm really unwell, and based on assessment, that nurse has determined that that patient needs to come in for further assessment and possibly see their physician as well. So that phone nurse will then connect with the nursing assessment desk, who then could also coordinate with the clinic nurse if that patient indeed needs to see their physician within the clinic setting. This is making for a much more improved, efficient patient care in the ambulatory area. And finally, another one of the other goals that we're looking at is assisting with the streamlining of patient care activities while not impacting any of the other patient care that's going on within the clinic. Some of those wait times might be increased for patients that are in the waiting area because out of an assessment that's either come from nursing or physician, it's deemed that that patient needs further interventions that might then impact the time that it's taking for that patient to be within the clinic setting, in the clinic space. So in bringing that work forward to our nursing assessment area, it is now freeing up and decreasing wait times, but increasing capacity within the clinics. So overall, we've just opened up the space in May. We are learning how to use the space to better support the clinic functioning and the flow. We always know that there's better ways and versions of the clinic and clinic functions, but as we evolve with the space provided, there is a potential for positive change for this space because we want to better serve our patients, their families, the staff, and our physicians alike. I'm going to hand it over to Chris now.
Thank you, Dawn. So you will notice signage up in front of the nursing assessment area indicating clinic A, B, D, and E in front of each desk. Nurses within the nursing assessment area provide support for their respective clinics as indicated by the desks they're sitting in front of. Thus far, we have only had one nurse supporting both clinics A and B, and another providing support to D and E, with the potential for further expansion in the future, which one-to-one support. So for example, nurse A providing support to clinic A and so forth. General thought is that activities brought forward to the nursing assessment area from the clinics and or patients can be navigated to the NAA from anywhere within the Odette Cancer Center for further nursing support. A profile of our current work through 7 days of activity through our soft launch features primarily symptom management support, facilitation of transfusion medicine, coordination and navigation for patients requiring urgent care needs, coordination of admissions, and complex patient care. There were a number of timely interventions on the part of the nursing assessment area thus far through our soft launch. A good example of that is a visibly distraught patient with high anxiety due to a diagnosis that was quickly escorted to the nursing assessment area, where she had an opportunity to discuss her concerns in a private setting, and a relevant referral was made and her anxiety was ultimately decreased. Another great example was of a timely intervention was a nursing assessment area nurse identifying an unwell patient at the T1 reception, quickly intervening and assessing the patient in a private space behind the NAA and escalating care as necessary. She was ultimately admitted to the hospital via the emergency department. Our goal is to rotate all staff through the nursing assessment area and hope to support as many clinical tasks as possible, with the goal being high quality person-centered care. While our current work is meaningful, we're hoping to also expand the NAA's role in providing holistic comprehensive care to include things like the expansion of complex patient care tasks, geriatric screening referrals to palliative care, and collaboration with patient and family support. Next slide, please. Thank you. Over half of the activities seen thus far at the nursing assessment area revolve around new patient support, complex care support, and patient wayfinding. One of the benefits of the geographical placement of the NAA on T1 is the proximity of nursing to the T1 reception, where patients whom are sick can be quickly identified and care provided. I believe this accounts for our current work profile, where complex care support and patient wayfinding both account for just about half of all tasks completed. But yeah, we are otherwise using this opportunity to explore workflows from a nursing perspective that is person-centered and least disruptive to their movement through the Odette Cancer Center, ultimately leading to them having a much better experience at Odette. Thank you.
Sorry about that. Thank you very much, Chris and Dawn, for giving a summary on something that hasn't really been in effect for too long. But of course, all the dedication to get it up and running, and it will get better over time. I'm just going to close off with a summary of just some of the key points. But before I do so, I just want to check the chat. Yes. I saw Dr. Gandhi ask the question if the nursing assessment area supported medical, radiation, and surgical patients. The answer is yes. What I was going to bring up too is, and we talked about this in some of our earlier ONUC meetings, the opportunity to also link patients to ONUC if there's availability there as well. So we will be doing that, certainly. Dr. Emenaker is asking, can clinics still be used for normal consultations? I'm assuming you mean by physicians. Yes, and there's the room at the back corner. I want to say 67 is still meant for physicians to rotate through clinic. Nursing is only taking 4 rooms on the side. So you've got the 4 desks up front. Directly behind that, you have 62, which is a clinical examination room for these urgent situations, COVID testing, additional injections, whatever might be happening. We have 2 infusion rooms, and then we have the injection clinic. So 67 on the other side has been used for physician flow through, and based on our clinic map, there are physicians booked in that room weekly. So I just wanted to close off, and again, if there are any last minute questions, please put them in the chat. But I just wanted to reiterate just a couple key points, just that all of Clinic C has been evolving over time. It's just sort of one thing has led to another. We've taken advantage of a situation where there have not been a lot of patients in clinic at the time, and having this additional space. We're going to continue to evolve and develop this. The goal is always to focus on what can we be doing for patients in that space that is going to better their experience, so decrease their wait times outside of clinic if they can get something done sooner, not tie them up in the chemo unit, create the space there, and also help manage something in the immediate, if there's immediate needs with regards to them not feeling well. But also looking to, by all of this work, this work all took place in the chemo unit and in the clinics prior to this. So that's all additional time and resource. So we're able to streamline the same care that still needs to happen, but in a different place to free up the capacity elsewhere. So we're continuing to work from that premise and look at that. Dawn mentioned this, the concept of having that nursing station up front. We are seeing the direct benefit, not only from our patients, also our colleagues have said, you know, how for the last 30 years have we not had a nurse sitting up front just to have access when they're trying to deal with situations. We're seeing it also with the patients coming in from other hospitals on stretchers that need immediate attention and need to get back to the ambulance bay. This allows people to find, you know where nursing is. If you've got an urgent situation, you just have a question or someone needs wayfinding, and certainly an opportunity for us to streamline. We did not get additional nursing resource with the opening of the Clinic C area and the nursing assessment. So we're redirecting where those care activities and nursing resource are going. So we're going to continue to collect data, and we'd like to put a little more formalized satisfaction evaluation together for patients and their experience in this area. And I'm just going to stop there. I see we've got, I'm just going to move on to the questions. And in the chat, one sec. So they might have already been answered. Yes, looks like it. I'm going to stop there. Are there any additional questions that anyone might have?